My name is Elena Sturman. I am the president and CEO of the Glaucoma Foundation. It is my great pleasure to welcome you all for our biennial medical education symposium. Founded in 1984, the Glaucoma Foundation has grown into one of the world's leading nonprofit organizations dedicating to study of glaucoma and the search for a cure. Our mission is to improve the lives of glaucoma patients here and around the globe. To achieve this, we identify and fund innovative research, promote diversity in healthcare through minority glaucoma fellowships, and foster collaboration among scientists and clinicians. This symposium is part of our mission. It brings together leading glaucoma specialists to share the latest discoveries and explore new approaches to treatment and patient care. Education also remains central to our work. Through our website, newsletters, webinars, and programs such as this one, we are committed to educating patients, physicians, and the public about glaucoma and the latest advancements in research and care. And now, it is my great pleasure to introduce the Foundation's chairman, Dr. Gregory Harman. Dr. Harman is in private practice in Manhattan, specializing in glaucoma and cataract surgery. His academic appointments include Clinical Associate Professor of Ophthalmology at Weill Cornell Medical College, New York Presbyterian Hospital, and Associate Adjunct Surgeon at the New York Ioneer Infirmary of Mount Sinai. He also serves on the medical staff of Manhattan Eye, Ear, and Throat Hospital. Throughout his career, Dr. Harman has been a passionate advocate for public education about glaucoma and for expanded glaucoma screening and early education. Please join me in welcoming Dr. Greg Harman.
Good morning, everyone. Good morning. Thank you, Elena. First, I'd like to thank all of you who are joining us here in the city today, New York City, and the many that are joining us virtually from across the country and actually around the world. The goal of this symposium is to bring together optometrists and ophthalmologists to explore the latest developments in glaucoma diagnosis and treatment, and to advance our standards for patient care. The Glaucoma Foundation, has always been very aware of the very important role that optometry has in the world of eye care. Working together with optometrists is critical. We realize that this is a job that we both need to tackle together, and we value optometry, and our work with optometry is really critical. Thank you. Today's program has been designed by our co-chairs, Dr. Murray Fingeret, Dr. Lou Pasquale, and Dr. John Berdal. I'd like to recognize Dr. Fingeret in particular for his leadership in developing the symposium. Thank you, Murray. We're grateful to our distinguished faculty for sharing their expertise, to our industry partners for the generous support, and to Pinnacle Events for providing academic credit for our U.S. participants. The first session is called Surgical Innovations in Glaucoma. It will be moderated by Dr. Gustavo Demeres and presented by Dr. Arsham Shebani, Dr. Poonam Misra, and Dr. Mitchell Ibach. Please come to the podium, doctors, and we'll begin. Thank you.
Great honor and delight to start this first session on surgical innovations in glaucoma. I'm Gus Demeres. I'm an ophthalmologist here in New York at Columbia University, and I'd like to introduce our first speaker. It's going to be Dr. Arsham Shebani and Dr. Mitch Ibach in combination, talking about trabecular outflow options. Welcome.
Good morning. Thank you. It's a real honor to kick off the first panel here on surgical innovations with my esteemed colleagues here. And we're going to talk a lot about trabecular outflow options and minimally invasive glaucoma surgeries. There was a recent, about 6 to 8 years ago, Ocular Surgery News survey sent to their readers asking them the most important innovation in ophthalmic surgery from 2010 to 2020, and it was minimally invasive glaucoma surgeries. And so that's where we're really going to start. I'm Mitch Ibach. I'm an optometrist with Vance Thompson Vision in Sioux Falls, South Dakota. We're an ODMD collaborative care tertiary referral center, and so my day is spent heavily in cornea, cataracts, refractive surgery, dry, and glaucoma. I maintain a large continuing care glaucoma practice. And so really the cost and prevalence of glaucoma has led to this category, which is not so new anymore with minimally invasive glaucoma surgeries. Before we dive into different procedures, let's really define the category as a whole. And so the goal of these procedures is to be ab internal. The surgeon's using a gonio prism, viewing the inside of the eye, and then most commonly working inside out. These are procedures that aim to get in earlier in the glaucoma disease process, provide a minimally traumatic surgery, similar to cataract surgery, extremely safe glaucoma surgery that provides at least modest efficacy. And so you can see your stenting options here. These are microscopic devices. They're biocompatible with the human body in comparison here to the size of a penny. And so what's the MIGS opportunity? This is data from Market Scope in 2024, their glaucoma survey. And if you look at the lightest green, mild and moderate colors, about 80% of glaucoma in the US in 2024 is mild to moderate disease. And this is really the sweet spot for minimally invasive glaucoma surgeries. If you go right below that, in 2026 in the US, we'll do over 5 million cataract surgeries on patients. And the data says that in this over 5 million cataract surgeries, over 20% of patients are concurrently taking a topical glaucoma drop. They have the comorbidities of cataracts and glaucoma. 1 million patients per year in the US, but we're not doing 1 million MIGS procedures per year. And so maybe this is the opportunity. I think one of the first steps to understanding minimally invasive glaucoma surgery and working in the space is understanding the state of the natural crystalline lens. Is this a patient that has a visually significant cataract? And we can partner cataract surgery plus MIGS. This is a home run, in my opinion, a timestamp in this patient's life, not to miss the opportunity to treat glaucoma. You can further increase aqueous outflow, you can turn down aqueous production, all while removing the cataract, which will hopefully also lower the IOP. And a patient who has refractive glaucoma, narrow angles, a highly hyperopic patient, don't forget about phaco and phaco MIGS in these patients. But MIGS is not only at the time of cataract surgery, we also have pseudophakic options. Could be stenting, the trabecular meshwork, goniotomy, canaloplasty, but helping these pseudophakic patients as well. For our first kind of session here on trabecular meshwork outflow options, I'll focus mainly on MIGS at the time of cataract surgery. And so here's our first device, the iStent. The iStent was really a trailblazer in the minimally invasive glaucoma surgery space. There's multiple iterations now. First generation iStent was a snorkel device. The surgeon kind of slid it in to the trabecular meshwork. This video here is now iStent inject, so second generation stent. And a couple differentiators here. First, the injector comes preloaded with 2 stents. So the goal is to place 2 stents about 2 to 3 clock hours apart. This is a much more straight-in type procedure. So almost like pushing a thumbtack into a corkboard. Surgeon's going to find the back wall of the trabecular meshwork, dimple, and then put in the stent. Big key here for the label. This is on label and FDA approved to be done at the time of cataract surgery in a patient with mild to moderate open-angle glaucoma. On the top left, you can see the anatomy of the stent. Really 3 parts. There's the very top, or what's called the head. That's going to reside in Schlemm's canal, has 4 outflow ports. Right below that is the thorax or the neck. That's going to sit in the trabecular meshwork, kind of anchored into place. And then the flange, which is viewable for us on gonioscopy. On the bottom left here, you see 3 stents. This is iStent Infinite, which is on label to be done as a standalone procedure, but I know some surgical centers, my surgeon is doing a lot of 3 stents now at the time of cataract surgery and has kind of went to that. Any of my peers, are you guys doing something similar?
With iStent inject as a standalone, I mean, I think TM options are fantastic. What we've noticed in our region actually is so many of our cataract surgeons are starting with like phaco TM procedures that I'm getting a little bit more into like real glaucoma with filtrations and other standalone options, not necessarily in the TM.
Yeah, I agree. I think a lot of times goniotomy is very commonly done, which we'll discuss shortly. But when I do use an iStent, I like to put the 3 in if possible. I mean, I think statistically finding the right collector channels is difficult. It's not something that's easy to do. So if you have more opportunity, it's best to try.
Totally agree. And so here's the FDA pivotal trial for iStent inject. This is published in Ophthalmology. Over 500 patients, all with the comorbidities of cataracts and glaucoma. Patients were randomized 3-to-1, cataract surgery plus stenting versus cataract surgery alone, primary endpoint at 2 years. And so bar graph on the far left, this is the primary endpoint of the study, which was a greater than or equal to 20% reduction in unmedicated IOP. So patients are washed off their drops. This is an important benchmark that the FDA uses, whether it's a new drop, laser, surgery. You can see it was in favor of patients who had combo procedures. About 7 millimeters of mercury, unmedicated IOP reduction. And then you can see on the right a 31% reduction from an unmedicated baseline from about 25 down to 17 out to 2 years. Here's data from our practice now. So real world study, this is 91 patients, all mild to moderate open angle glaucoma, all had cataract surgery plus stenting. They weren't washed off their medications. On average, got about a 3.5 millimeter of mercury IOP reduction, and the average patient got off about a half of medication from 1.4 down to about 0.9 in our study. This is looking at IOP benchmarks here, or targets, so kind of mirroring the advanced glaucoma intervention study, looking at the percentage of patients who get below a certain benchmark. You can see shown in yellow is less than or equal to 18 millimeters of mercury, and then shown in orange is less than or equal to 15. Next device in the trabecular meshwork bypass state is also going to be done on label at the time of cataract surgery, which is Hydrus. Hydrus is a bigger stent. It's an 8 millimeter stent in length, and it's more of a sliding in procedure. So surgeon kind of pierces the TM, and then Hydrus is going to not only give us this trabecular meshwork bypass, but it's also going to kind of stretch and expand Schlemm's canal. So trying to work a little more distal maybe here with Hydrus. This is going to span about 3 clock hours of the angle. So if you're managing these patients post-operatively, you're going to have a goniometer. You'll see about 3 hours in the angle here with Hydrus, and there'll be a flange that's pointing back towards us here. So again, at the time of cataract surgery, this is the Horizon trial. This is again over 500 patients in this study, randomized 2-to-1 now, cataract surgery plus Hydrus versus cataract surgery alone. Primary endpoint initially was 3 years, and there's extension studies out to year 4 and year 5. And so same primary endpoint, percentage of patients who achieved that greater than or equal to 20% reduction in unmedicated IOP was in favor of the combo patients. At 4 years, this was presented at the American Glaucoma Society meeting. Almost 2/3 of patients medication-free after cataract surgery plus Hydrus. And then the second bullet, I think, is a really important one. Less incisional glaucoma surgery intervention in the combo group. And then finally, the 5-year data, which I think is really a big win in the MIGS space. This was, to my knowledge, the first randomized controlled clinical trial that showed cataract surgery plus Hydrus slowed or lessened visual field progression compared to cataract surgery alone. Here's a comparative study. Now, this is published in Clinical and Experimental Ophthalmology, and this is, again, a real-world study. It's on label, so patients either had cataract surgery plus iStent inject or cataract surgery plus Hydrus. They matched a consistent cohort, so 75 patients in each group, pretty similar preoperative characteristics, and they watched these patients for 2 years. On the left is IOP reduction. So from a baseline medicated, right around 18 millimeters of mercury. Cataract surgery plus Hydrus achieved 2.3 millimeters of mercury IOP reduction compared to 3.1 in cataract surgery plus iStent inject. On the right is medication reduction. So again, these patients weren't washed off medications, baseline right around 2. Cataract surgery plus Hydrus, a half medication reduction, or every other patient got off 1 molecule. Cataract surgery plus iStent inject, 1 full medication reduction. We're going to move out of stenting the trabecular meshwork and into goniotomies. In one way or another, all of these procedures are unroofing, cutting out, removing, ablating the trabecular meshwork. Dr. Birdall was so anxious about not being here, he narrated his video so we could hear his voice.
I'd like to make my first move in a backhanded manner from left to right, since I'm right-handed, and I engage with the Cahook dual blade moving from left to right, and then I come back in a forehand manner from right to left and complete the goniotomy. The Cahook dual blade has a unique design that allows you to lift and excise the trabecular meshwork. You can see as I come back with my capsulotomy forceps that I'm able to grab the tissue, remove it, and now a very clean goniotomy has been performed.
And so multiple devices in this category. There's Trebex Pro, there's Scion, which has a small window. I know some surgeons are using almost a bent needle to remove some of trabecular meshwork. Big key here is this can be done at the time of cataract surgery or standalone. In our practice, we do more standalone goniotomies than we do at the time of cataract surgery. And then the final procedure, which we'll cover, is a combination canaloplasty plus trabeculotomy. This is commercially known as OMNI. Really 4 steps here. Surgeon's going to kind of pierce the trabecular meshwork to access Schlemm's canal. And then this blue microcatheter will get pushed forward. It's kind of a roller ball type device, forcing open the canal, breaking any adhesions in Schlemm's canal. Then the surgeon will start to reverse that microcatheter. As the microcatheter is coming back into the device, it's going to disperse viscoelastic material, this gel material, kind of working through. I almost think of it and talk with patients as almost putting Drano through the pipes, and so working into Schlemm's canal and the collector channels. And then the final step, that microcatheter will go forward again, and you'll see the trabeculotomy almost getting under the TM and then pulling it or stripping it out. Again, this can be done at the time of cataract surgery or standalone. If we're doing cataract surgery OMNI in our practice, it's most likely a severe glaucoma patient. The labeling and some of the insurance reimbursement works better in our MAC for these patients in the severe glaucoma space. Final study here. This is Gemini 2. And so to compare apples to apples, I have a cataract surgery plus OMNI study here. We're probably 75% standalone OMNI in our practice compared to combined. But this is 66 patients, again, all washed off their medication, had cataract surgery plus OMNI. On the left, you can see about a 7 millimeter of mercury IOP reduction out to 3 years. On the right, 74% medication reduction from 1.6 down to 0.3. My biggest adverse event kind of concern with OMNI is having this iatrogenic hyphema, so some blood in the anterior chamber. It's almost always self-resolving, but it is important to talk with patients about that. Clinically, probably 15 to 20% of my patients on post-op day 1 have some of this.
Great segue here, actually. So what I'm going to talk about for our in-person virtual audience is actually how to set yourself up for the changes that are coming down the pipe. I do think that technologically we're actually pretty mature with what we have. You're going to see iterations of devices in the trabecular meshwork space. But a lot of this is still, it's a canal that's got a very set width and size. And until we get downstream, and there are technologies potentially that can get us a little bit more downstream, a lot of what we do will be iterative. And so a lot of these principles do apply. And my disclosures are relevant for this talk. So one of the biggest things to think about is just your visualization. Any surgeon that starts, you have to be able to understand your anatomy. And this was a patient that was sent in progressing at pressures that were around the 10 to 12 range. And it really does look like that's the trabecular meshwork until you indent and you realize that that's where the TM is. And so it starts in clinic. If you don't identify these patients properly and you put a device in that patient that had plateau, more than likely you'll have post-peripheral anterior synechiae, you're going to have blockage of a stent if you place it that way, and you're not treating the proper mechanism. And so one of the things I say is TM is really going to be kind of like a paintbrush that will paint the pigmentation left to right. The Sampolices lines that you see are more like the paintbrush is stippling or dotting that pigment. They can both be pigmented, but it looks different in those cases. In a lot of my chart notes, if I don't see good pigmentation, I will put in there trypan. The trypan's not for the cataract, it's actually to visualize. You can do this thousands of times, and there are still angles that will confuse even the best person doing gonioscopy and intraoperative. And then if you push too hard, you start to really lose your view. So there is a finesse with what we do. This is not a simple thing. And I think that's one of the other things, with us that deal with teaching and you're learning and you're teaching people that are doing these for the first time, you start to see how difficult this is. When you start to see surgeons doing it after, again, thousands of operations, it's a very different scenario. So when we say en face, this is the view that we're trying to get. We're trying to see the TM just above the scleral spur, above that ciliary body band. but it's very difficult to get that surgically. So what I wanted to kind of show was how to
Shabani here,
actually
operating with
visualize
my fellow
this.
Jessica Liu. We're going to
And
demonstrate how
I don't know if there's a way to mute it, but anyway, I'll let myself talk.
Place the gonio prism directly on the eye. We're
All right, perfect. Thank you. So what we're doing here is we put the gonio prism, and we can mute everything in this talk if there is the audio. We put a gonio prism on the patient, and we're just turning their head. We're not turning the scope. And you can see that the angle's not in view. But as we turn the scope, now you're going to see that's that typical look that you see that people kind of 2x when they're turning the scope. But now the angle's in view, and you get a really nice picture of the TM, the spur, and then the iris processes in the periphery. But as the patient starts to look toward us, we lose that view. And that's the entire point of like, how do you optimize the view? Most of the time, if we're not seeing things clearly, we're not rotating the eye far enough away from us. I'm not saying the head, because that actually puts you in a surgical conundrum where you're operating top down. This is more get the eye to look away from you so you can truly see it on floss. Because in your perspective, the more they look towards you, the more the tissue planes are going to blend into one. And the other thing that I kind of like to do as well, you know, I'm not a big fan of like combining devices. And even when that was like a huge thing, there was an advantage of dilating the canal before placing stents. So we actually just developed our own like little needle benders. This was one that on a 30 gauge needle, it bends the needle in a certain curved shape. So it's not kinked. It's just a 30 gauge, like a 5/8 inch to an inch. And you put it on your viscoelastic cannula, you can incise into the TM, and we would inject OVD. And that's how I would start training the Hydrus device. That gonio prism is another one that we worked on that was now marketed as hands-free. I don't own any stake in it, but it was really designed to get the handle off so I can manipulate it while the resident or fellow was trying to learn. But these were little iterations that we made, and I think it's important to kind of think about when you start in this space, how do I get into the canal? One way is do not overpressurize, but that's why this became a thing with using devices to viscodilate before placing stents. And you have to understand the anatomy. The TM is not just one tissue plane. It's actually consisting of three. So you have the uveal portion, the corneoscleral portion, and the juxtacanalicular portion. And you can actually get it between those spaces. And that's one way the devices might not work. So Mitch showed a nice just intro on Hydrus, but this is the first Hydrus I ever did. So if you look, you can actually see that that device is behind something, right? It's behind some tissue plane. There's little iris processes that are going above it, but it just didn't look right. For like a TM stent, you shouldn't have that amount of transparency. And when you look, this is still, again, behind a tissue plane, but there's a little bit more opacity between me and the stent. And what does that look like side by side? Like this. And so either I can jam something into the TM, I could jam something into the sclera, which this device can do, or get it in the canal. And so rule number one, if you're trying to optimize these things, is get them in the right place. What happens when they're in the right place? Well, one of the things we used to do, and Poonam kind of mentioned this, it's very difficult to like nail a collector channel. There are ways that we can image, but to be honest, like efficiency-wise, that's not really going to be useful. But to show you the power of what these things can do, we used to identify collector channels. So we would place a Weck cell sponge somewhere just along the limbus, and I would try to see like how those vessels would react. When you compress a vessel, you're kind of giving it a little bit of backflow, so you'd get a little bit more red in an area. And when you released it, especially if you raise the pressure in the eye, you could clear out some of those RBCs. So what you're doing is you're pushing a little bit of aqueous or BSS fluid through the collector channel system. And if you drop the pressure in the eye, and you haven't made an incision in the trabecular meshwork yet, you might see a little bit of blood reflux back in that area. So that's how what we would call target an area to place a stent, especially when the stents were like, all you had was one stent that you could do and it was very small. Now we place the stent. Look at what that does as far as connecting the episcleral venous system and the collector channel system to the anterior chamber. You drop the pressure in the eye and you get blood refluxing back in. And here's another pearl. If you see blood coming back at you in a very diffuse way, and it's kind of moving quickly, almost like this tidal wave coming at you, that is not reflux bleeding. You've actually probably hit a peripheral iris vessel or ciliary body band. Reflux bleeding out of collectors is very focal. It's a dot that comes towards you, and that one's easier to manage. And I'll show you an example of what the other bleeding looks like. But if you get that, you're not in the right plane, stop what you're doing, and you're going to have to really look to find your TM because it should not come in that quickly. But we raise the pressure inside the eye, And look at what happens. Like the blood obviously is clearing out of the anterior chamber, but now it's really moving through the collector channel system. And within a flash, it has evacuated the blood out of that space. And that's the difference between placing a stent or opening up an incision in one of these high flow states versus not. Now, does that matter in the long run? There is some data on putting stents in areas of pigmentation that might have higher flow that could end up in better results. I think population-wide, you get enough people, you're going to find a statistical difference in anything. But this is just something to consider. And I think as we look into the future of TM-based surgeries, it's going to be more downstream than what we're doing now, looking just at the front or the TM. But this really took off, and I think for good reason. And early on, what we were doing was taking fibroprolines. We would bulb this suture tip, and we would, again, turn the patient's head, use a needle to make a goniotomy incision, and then place this suture ab interno for 360 degrees. This was actually a patient who was very young, uveitic, pretty severe field loss, not your typical that you would think like a TM surgery would function for. But the mechanism really was combination twofold. Chronic steroids, so a lot of what was happening was probably in the TM, and then also the uveitic component blocking the TM. When he had inflammation, I was really worried about a tumor device in a patient that was in their 30s. This procedure actually lasted over 6 years for him. He ultimately did need a bear belt, and this is how it goes. But that was 6 years of a tubeless operation. Now he's actually writing chronic hypotony that we're allowing to happen because his vision went from 2025 to about 2030 minus. But I think we're going to preserve his vision in the long run, so we're leaving it that way. But this procedure, you're 360 degrees, bring a suture in, and now you're stripping. What happened with this was sometimes you would hit a bridging vessel and you wouldn't know it. We would see some pretty massive hyphemas, and this is actually his case. This was his day 0 case. It taught us a lot about how to manage hyphemas and what we were doing wrong. We used to, after these procedures, fill the eye with viscoelastic. Well, what would happen, and I started having patients actually take pictures of their eyes, they would have a layer of viscoelastic at the top, but then blood layering at the bottom. So I had this mix of blood and viscoelastic. So then what we started doing was raising the pressure and leaving viscoelastic in there just to keep things from refluxing back in the eye. And we would actually see a reduction in the hyphema. So then we started backing away from leaving viscoelastic. And I think now universally, people don't really leave a lot of viscoelastic in the eye after angle procedures. We just leave the pressure elevated to ensure that there's reflux and outflow. And when you look at why these things are important, because a lot of people will say, well, you look at the Hydrus data, it's just very minimal gains between the phaco group versus the phaco-Hydrus group. That is true, but you look at the light study, and it actually shows very minimal differences between the two, but the hard endpoints are real. If you look at Gus Gazzard's paper, that is a very real outcome with visual field progression, and then also secondary surgical interventions are reduced whenever we do these procedures in combination with cataract surgery versus cataract surgery alone. But the other big one actually is the IOP spikes. When you have surgeons doing same-day IOP checks, I think a lot of people thought, oh, that was a way to skip the day 1 visit. It actually isn't. It's a safer play in a glaucoma patient, to be honest, checking them at 3 to 4 hours post-op versus a whole day, where they could be riding a pressure of 40. And the MIGS procedures do reduce the IOP spikes, especially early on. Can they still get them later? Absolutely. But early on, the data is actually pretty clear. And if you look at anecdotally, even in your own centers that you're doing, these patients do have lower pressures than the non-TM treated patients after cataract surgery. And then this is actually showing your odds ratios for IOP spikes after phaco. The biggest ones are vitreous loss and having glaucoma. And so TM procedures, I think, are actually very critical, especially done before the cataract surgery, because if you do have vitreous loss, that patient's already high risk for an IOP spike, but you've already had the glaucoma procedure done. And so you're reducing that risk. And I think it's critical there, which is why we start with it. I like performing them before cataract surgery. There's a couple of reasons. One is psychological, especially if you're starting out in it, get the hard stuff out of the way. You're used to the phaco, do this one first so you're not thinking about it the whole time. It ensures the glaucoma procedure is done for the reasons that we mentioned. The visualization generally can be better, especially if the case has taken longer for phaco. But I like the fact that it is essentially rinsing out the system. Not that I think that that's doing anything in the long run for pressure, but you're not chasing your tail trying to get the blood out of the eye at the end of the case, because a lot of it has kind of been pushed downstream. And it removes blood as you reflux. And you just need to make sure that you manage the blood, because sometimes when you get a lot of reflux and you let the pressure drop, this stuff can go behind lenses. If you're doing like premium work with like toric lenses, they might not be so happy if it's behind the capsular bag. But these things all matter. Really making sure you have good seals, raising the pressure up at the end of the case. And then the post-op course, I think a lot of people don't really understand like what they're managing. And when you look at the post-op course, steroids for hyphemas. In trauma, I did a full year running our trauma service at WashU and dealt with a lot of hyphemas, a lot of ruptured globes. The steroids for hyphemas really, I think, have been pushed a little bit too far. Steroids are designed to prevent like a fibrin scar formation, like in the peripheral angle. It's not designed to get rid of the red blood cells. Actually, the way to get rid of red blood cells is get them off the steroids so the body can actually phagocytize that material that's there. So once your layered hyphema is gone, start getting the patient off steroids. Treat it like a regular cataract surgery. Even for the bleeds that happened that were larger, don't chase microhyphemas. And I look on gonioscopy, if I start seeing a little PAS forming to a stent, at the beginning we might use pylo. They're actually exquisitely responsive to pressure spikes if they had them to pilocarpine. Biggest reason, we just don't use it very often. And then the glaucoma medications, generally like the day one, I will stop. We've maintained them throughout the first week, and then we start to peel them off after they're off the steroids, because you can still see pressure spikes. So we will maintain them until they're off the steroids. And I do want to talk about the mydriasis. I don't think many people are doing 360-degree sutured GATs. But the peripheral iris vessels actually carouse through the angle. Some of them are visible, many of them are not. If you think about like zoster, whenever you have zoster, you'll get these sectoral areas of iris atrophy. The same thing can actually happen with angle procedures. If you nick one of those larger feeding iris leaflet vessels, they come in radially. And so those big hemorrhages that would happen, rarely we would see a patient with a little bit of iris atrophy, or the sphincter was no longer functional. And the extremes were sometimes mydriasis, where it was not functional if they had major hyphemas, especially after high pressures. But another thing to think about, which is why I kind of clued you in, if you see the blood coming at you kind of like a tidal wave, even though it looks like it's coming slow, that's not reflex bleeding. You're not in the right space where you're working. And if you're going to jump into it, and I think a lot of people have gone into MIGS procedures if they have these patients, but there's still a large portion of surgeons in the US that still don't do them. If you're diving into it, you just really need maybe one angle surgery, a stenting, and maybe a stripping option. And I think if you're really treating glaucoma, you still need to have subconj options for these patients. This is not a disease that you can just treat with the TM alone. And your ideal cases, be familiar with your TM anatomy like I showed you. Use trypan to stain the trabecular meshwork. And if before you start, it's okay to turn your routine cataract surgeon patient's head over to the side, take a look at the angle, be like, oh, I can visualize this. Maybe put the viscoelastic cannula in there just to follow the anatomy. That'll build a little bit of confidence until you launch into these procedures. But don't work on angle closure to start with. These are open angles, generally earlier disease, not on blood thinners preferably, just because if you're in the wrong spot, that's hard to control. And pressure's near target. Once you get a sense of what you're doing, then you can kind of start pushing the envelope a bit. And before I conclude, I do not think that we're doing justice for patients basing it off of disease severity. Our biggest lack right now, and things that we're working on internally, is really outcomes based. How do we predict who's going to benefit from MIGS, not based on their cup to disc or their disease severity, but on other factors that maybe AI can actually help with imaging on your IOL master to determine what patients are potential candidates versus not. But thank you so much for your time.
Thank you. I would like to invite now Dr. Poonam Misra. Dr. Poonam Misra is a glaucoma specialist at Manhattan Ear Throat Hospital, Northwell, and she's the co-director of the Glaucoma Fellowship. She's going to be speaking on new developments, new surgical developments. Thank you.
Slide, sorry, just want to confirm. Our next slide went over to Dr. Shaybani's next talk. Can we
Can we change that?
switch? I don't want to ruin
Should I
his
give
thunder
it?
with-
Because I know it's on like one go, maybe.
Oh, they did one go?
Yeah, I
Okay.
think all the slides are together.
Um,
I think. All right, yeah,
Can
go
we-
through it.
can we skip?
Not
Oh,
ruin
you
anything.
got it?
I'll go. Oh boy, spoilers, a lot of
Yeah,
spoilers.
that's right.
Shield your eyes. Amazing. Thank you. Well, thank you so much for having me. It's such an honor and privilege. I've been in the audience many times for these meetings, so it's really exciting to be on the other side and see so many distinguished faces. So it's an honor, and hope I can follow these two amazing acts. So I have no significant financial disclosures relevant to this talk. I'm going to be discussing a few of our innovations. We've already heard about a few of them, so I won't be redundant, but I do want to discuss kind of how you choose what to do, because the best thing about our field right now is that there has been such an explosion of devices, of technology, of ideas about how to treat glaucoma. But the downside is, how do you take all of that in, and then how do you apply it to your patient? When you're sitting in your room with your patient, it's you and them, and they want your expertise. So how do you kind of parse through everything that's going on? And a lot of what we wanted to discuss today is, how do you speak to patients? How do you know what's best for them in their state currently? So we've just heard a little bit about traditional MIGS, which I'll cover a few other points about. I want to mention the suprachoroidal space because I think it's something of interest lately, and it's not new to many people, but it is something of an area of interest when a traditional MIGS may be not working, or when there's room for something else. Some of the subconjunctival space innovations, how to assess candidacy. We're going to branch into our co-management strategies, which Dr. Ibach will follow up with as well. And then how do we manage our expectations of this disease? So we've discussed a little bit about our traditional anatomy and the traditional MIGS procedures we have. A target is something that is debated many times in our meetings and when we all speak as colleagues, is that, are we targeting just a number? Are we targeting the degree of visual field loss? Are we targeting the patient's lifestyle? I think we have to put all those ideas together now, and we have to figure out what is the overall target for that patient. And the concept of personalized medicine comes up, in that we need to decide, what are we treating here and who are we treating? We're not just trying to achieve a number of 14, which many of these great studies that we turned to from many years ago, we were really trying to target a number, but I think it's so much more than that. So the MIGS space is allowing for it. Our glaucoma toolbox is expanding daily, and this is just a brief list of things that we have. So a lot of the left-sided procedures are office-based, things that we can do easily for the patient with minimal risks. But again, these are things that may be introduced very early in the course of their disease. Our trials, especially the light trial, has showed us that SLT is a very early option that's excellent for patients. And I offer that almost readily to every patient I meet who's on any drop, because I think it's a way to reduce a dependency on drops, to increase compliance. If they are on a couple of medications, maybe if we can get them off of even one, I've seen it really change the lifestyle for a lot of patients. Patients who don't have a caretaker, who are older, who may not be able to instill their drops, have any sort of physical limitations. This is something, an easy low-hanging fruit that we should offer everyone. Intracameral implants are a big area of interest now, with things like the iDose and Durista that are involved. These are other ways that you can reduce dependency on drops. And so I know we're talking about MIGS in a surgical OR fashion, but there are things in the office that we can do that we are addressing glaucoma early. And when we talk about interventional glaucoma, I think we need to include those. Then when we go over to operating room procedures, the list is endless. And even as we were just discussing this morning, there are things that I have left off here that we could add on. You know, canaloplasty, goniotomy are really bread and butter now for a lot of us glaucoma specialists. Things like suprachoroidal stenting is earlier in its development, and there are things yet that we need to learn, but still something we should be looking forward to. And then I'll talk about some of the subconjunctival space procedures. And I will mention trabeculectomy and tube shunt, because as I know, as bad of a rep as they get, at the end of the day, these are some of our old standbys, and they are tried and true for a reason. So we've discussed some of the MIGS specifically. They all have a lower safety profile. They do often have a shorter recovery, a less risk of bleeding. And I mentioned bleeding in the sense of risk of suprachoroidal hemorrhage. But as we've heard, hyphema is a very common finding with a lot of these patients. So although we find things like a shorter operating room time, we do have some complications we need to be aware of. Now, canaloplasty can be done in a segmental or 360-degree approach. Viscoelastic is used to dilate and expand Schlemm's canal, we discussed. And the IOP reductions can be significant, anywhere from 5.6 to 7.1 millimeters of mercury in a study by Dr. Radcliffe. And this was over the course of 36 months. So the longevity of these procedures is significant. Standalone canaloplasty in some patients, showed in Dr. Gallardo's study, did bring down patients on their medications and also reduce their IOP by up to 7 points. So when you're talking about what their target IOP is, many patients need a reduction of 5 to 8 points in more advanced disease, and these procedures can get us there. But I think a big question patients always ask is how long will this last for, and will I have to do it again? And the answer is maybe. And a lot of patients, since we are diagnosing earlier with the advent and developments in OCT, we are picking them up earlier. We are going to be treating them for decades of their life. And so offering them a 12-month success rate may not be that appealing, but you have to understand also is what is that 12 months going to look like? I have patients who have their child's wedding coming up or they have something relevant. And so they don't want to have a trabeculectomy and a bleb that I'm monitoring weekly for the next 3 years. So it is significant, although some of these studies may seem shorter, they are offering some real-time assistance to patients. Goniotomy and sizing into the trabecular meshwork is just a beautiful procedure. I think that there's an instant gratification and success when you see the CM splitting open and you have a nice canal view there. And in a lot of patients, this is a perfect procedure to start. Patients who are on steroids frequently, I see a lot of patients in my practice who have had corneal transplantation. They are chronically on steroids because of the graft success rate. And so these patients need something to lower their pressure. And after they've already undergone a corneal transplantation, they may not want to now undergo tube surgery or trabeculectomy. And so opening their canal, assuming the view allows it, is a nice way to reduce their pressure since we know that steroids are affecting the trabecular meshwork function. And if we're able to do that and reduce the need or delay the need for a tube shunt surgery, a lot of them are very, very pleased with that. There are so many ways to perform goniotomy, as we've discussed. On the left here, you have all of these different ways. I wanted to mention that there is a lot of debate about whether you need 360 versus 180. I don't know, Dr. Shabani, what your opinion may be on this. I personally always do 180 to start. 180 plus, I call it, because I'll usually use whatever catheter I'm using. Oftentimes the eye track, because I do like to have the lighted catheter, which shows me where I am in the trabecular meshwork, also to ensure I'm not diving into the suprachoroidal space as I'm traveling through the canal. But I usually will do at least a 180-degree goniotomy with the device, and then backwards go and include another maybe 70 to 80 degrees. So I do like to do that. Dr. Shabani, what are your thoughts?
I totally agree with you. I mean, and that's physiologic data to back you up too. Like if you look at outflow facility, and these are older studies, but they plateau right around 6 clock hours. And then when you look at the data, actually, it pans out to about that, around 180 to 200 degrees. Population based though, so means between groups, that's about equivalent for IOP reduction and med reduction in patients that have had 360 degrees.
Yeah. And personally, I think the 8-ball hyphema that we've all experienced when we've done a 360 is not the greatest post-op day one experience. So if we can reduce that, I think it's worthwhile for the patient and for us. And if efficacy is going to be similar, I think it's makes sense for us. Some studies have shown that Cahook dual blade goniotomy, which is really going to access majority 90 degrees, but maybe a little bit more, has been just as effective and reliable as doing a 360 GAT. So I think we have to discuss with the patient what we're trying to do and understand where are we going to get. Now, the suprachoroidal space, currently the major device we have that is being used is the Alloflow. Now, this device is injecting a stent into the canal that is made of a material that is less prone to fibrosis. It's a scleral stent or spacer that you can place, and you can place multiple spacers like this. And the idea is that you're holding open the suprachoroidal space to allow aqueous to leave the eye. Now, the viscodilation during this part is dilating into the suprachoroidal space to tamponade heme and also to allow more aqueous to travel through the space. Obviously, the big major risk here, we've all been told in all of our training to not enter the suprachoroidal space, is bleeding. And so there is a real risk of this. Unfortunately, if that does occur to a significant extent, patients may have an IOP spike. So knowing what you're doing and knowing your anatomy is key. When you're entering the space, you're going to be tapping down on the ciliary body, so you're trying to create that cleft. But in doing so, you have to expect that you're going to get some reflex heme there. So the candidates in this may be someone who's failed a traditional trabecular meshwork intervention, but who doesn't warrant yet a minimally invasive bleb surgery, a trabeculectomy, or a tube shunt. Obviously, we'd like a patient with open angle with minimal scarring, but if someone has conjunctival scarring, this also could be a good option. Risks, as we've discussed, hyphema, cleft closure, and then the need for further surgery. I want to mention a bit about glaucoma tube shunts. I know we're discussing MIGS, but I think we have to also discuss with patients where this can lead if their disease is severe or if it progresses in the future, as we know that it will. We have some new devices in this space. The Paul glaucoma implant is undergoing trials right now, currently only available internationally. But the development of these devices like the Paul is that it has a smaller lumen size. And what that's going to do is lower your risk of hypotony. So the biggest fear with a lot of these tube shunts or trabeculectomies is pressure going too low, especially leading to a suprachoroidal hemorrhage. But this device is actually a very thoughtfully designed with that smaller lumen size so that there is not as much aqueous outflow. uncontrolled aqueous outflow. It has a more compact plate design. So a lot of tube shunt surgeries, we discuss the risk of diplopia. It is far more invasive because we're working near the extraocular muscles. This is thoughtfully designed to reduce that. And then it also is a device used with a ripcord to try to regulate the initial outflow. A meta-analysis is showing a very nice reduction of medications and IOP from baseline. But one of the downsides is that there are some notes of early tube exposure with these patients and possibly more fibrosis. I think that leads to the technique of how it's used, whether the ripcord is removed on time or not, or if there is a delay, then perhaps they are going to be more prone to fibrosis. So like anything, I think you need to know what you're doing and also need to prepare the patient that there may be hiccups along the way, and how are we going to deal with that, whether that means using some aqueous suppression early on while you're watching for encapsulation to occur, or keeping them on glaucoma medications temporarily, and then understanding that the goal would be to remove them. Some other upcoming implant options are the Calibri, which is a device that's designed to give a more personalized in-office control over aqueous outflow. So one of the big concerns with a trabeculectomy is that we're relying on these very tiny 10-0 nylon sutures to regulate outflow here, and that feels very scary. Doing laser suture lysis is definitely something that's a little bit can kind of take your breath away, because you're not quite sure if you cut it and now the pressure drops and the eye sort of collapses after trabeculectomy. You have to be ready to either inject some viscoelast or go back to the OR. So something like the Calibri actually has a titratable mechanism where on the right there are outflow channels that can be lasered in the office to open or close them, which almost sounds magical, but their studies are actually showing good success in finding patients are having successful outflow, but it is regulatable. And that's really nice, because in a trabeculectomy, once you cut that suture, you've sort of gone down a road that's hard to come back from. So this is an exciting a device that we can look forward to. Another option is the VisiPlate, which is actually a tubeless device that facilitates subconjunctival outflow through these microchannels. It's a very thin material and currently undergoing feasibility and biocompatibility studies and opening up to clinical trials soon, hopefully, but it's showing a 20 to 40% reduction in pressure in the trials so far. It's almost difficult to see here, even on the zoomed in photo. I was wondering if anyone will be able to pick it up, but it has this sort of rugated surface, almost like a sponge, and the fluid that passes through will then disperse more diffusely. A lot of the blebs that we've seen that are long-standing from trabeculectomies, you see this small, very encapsulated bleb. This is going to allow for more diffuse flow, and I think, especially when we're teaching and my trainees are doing their trabeculectomies, I always emphasize you want to have a nice dissection to see diffusion of your conjunctival elevation after a trabeculectomy. Once you get off the ground with that, you have pretty high rate of success. But if you end up being too shallow or too encapsulated, that's when fibrosis is really a problem. So VisiPlate may overcome that by giving you an early diffusion of that outflow. And finally, I want to mention the PreserFlow microshunt. As we know, this is something that has been sort of toyed with us. Internationally, it is available, and we have some really great results we've seen there. But similar to a tube shunt, it is going to provide outflow, but in a more controlled fashion. The lumen was designed to allow outflow that is more controlled and hopefully reducing risk of hypotony with it. It is designed also to have this little flange that will hook into the scleral opening. So this is done as a subconj procedure, open conj, but hopefully that will keep it anchored. The Zen that many of us use as well, one of the issues is migration of it and securing placement. So this is sort of trying to defeat that problem we run into. So what are the benefits of using the subconjunctival space? These smaller implants are more friendly material, less resistance to the body that they're not going to fibrose over. If we can find a way to control the reduction of the IOP early and not have too low pressures, we can reduce the risk of suprachoroidal hemorrhage. And then if there are some devices such as a VisiPlate, you do not need mitomycin C, but still establish continuous flow, that would reduce risks further. So which procedure is best? I would say there is no perfect procedure. I think you have to start somewhere, in a conversation with patients. You sort of can tell with your patient whether they want to hear this whole gamut like we've spoken about today, or they want to just sort of be told this is where I think we should start. I think it's appropriate to choose what you think is best based on the anatomy that you see. Do you have access to the TM or not? Are there PAS? Do they have a cataract? I frequently will expose them to MIGS very early on. The minute I discuss cataract surgery, like Dr. Ibeck said, I think it's easy to mention goniotomy or for a stent. There are some real risks, which I'll be presenting some cases later with some not so happy initial post-op period, but they can have really long-term success for what they're looking for. It's very important to talk about post-operative limitations and concerns. I think patients are not aware of what they need to do after surgery for them to have success. And so it is a team between our team, whether it's our optometry team and our offices, as well as the patients, their caretakers. So having a group discussion is very important. I will often ask a patient who's on the fence about surgery to bring a family member with them who's going to be taking you home that day so we can talk about recovery time and things. And I want to mention trabeculectomy because I think there's a reason why every study ends up comparing themselves to it, and it is not just because they have to. I think trabeculectomies are very appropriate in many patients. They can be titratable, revisable. They will get those lower IOPs. So when you've done your MIGS surgeries, when you've done other things, and you get to the point where that field is still deteriorating, I think you have to leave yourself open to this idea that a trabeculectomy may be right for the patient. And although it is overwhelming the amount of post-operative visits with these patients, if you have great co-management skills, which is what we'll be discussing a little bit later, I think they are very, very successful procedures. In terms of co-management, I know Dr. Ibach will pick up on this. It's important to discuss what the pre-op concerns are, whether cataract surgery is relevant, and that includes an optimal refraction. Post-operatively monitoring with steroids, cycloplegia, and lubrication. Simply just improving the surface of these patients is going to improve their experience. Following them up by establishing a new baseline with their visual fields and testing is key also, so that you know if you have achieved the goal you're looking for or if maybe they need more aggressive therapy. Glaucoma is a marathon, not a sprint. As we're hearing, we're going to have to try many of these options in all of our patients. Understanding our goal now and in the future is important to have a conversation at the time. But I think we have many, many options. I think that might actually be a double-edged sword for us right now. So I'll kick it back to my colleagues here, and then I'll be back for some cases. Thank you.
Thank you. Thank you, presentation. I apologize for having inverted this sequence here. I was a little bit confused, but I'd like to invite back Dr. Arsham Sheibani. I hope you appreciated the break.
Yeah, no, it's good. It's good. I think they appreciated the break from my voice. So we'll talk about some of the new innovations, and really this talk was going to be about standalone options. And I love that Poonam kind of mentioned this. In my mind, like when you really think about standalone options, right now our gold standard still is like subcon surgeries. And I'm going to start with that, some of the new innovations, and touch on some things that she highlighted here. The calibrate device that she mentioned, this was maybe like 4 or 5 years ago, or 4 years ago. We started with I did 70 rabbit surgeries, modifying the device, trying to figure out how we can get it to actually work and calibrate until it's now finally in human studies outside US, and already now in FDA trial with a couple of centers starting out doing the device. But the purpose was, how do we have a reversible, titratable device to get the pressure back up if we overshoot? And what it is there's a cartridge there that you can use a laser, like a 532 standard green laser is what we've been using. You can use a red laser in the office. So if you have a laser suture lysis laser, you can use this device, where essentially we are lasering these nitinol paddles that move side to side as they absorb a little bit of energy, and they open and close certain channels. And our goal is to lower the pressure and titrate it kind of like you would with like a trabeculectomy, where you pull a suture or you laser suture lysis suture. But in the office, if you really get to bad catastrophic hypotony, you can't reverse it, and sometimes that's a trip back to the OR. This was a proof of concept. Can we actually get the pressure back up if we get it too low? And so the procedure itself, if you watch the video, it's for a glaucoma surgeon, it's going to be very standard. It's a 1.6 millimeter wide device. The blade is exactly that width. And it's not truly a stab incision. We want a tunnel, and you want it really flat down against the iris. There is an inserter. The material is actually silicone on the posterior side. The cassette that houses it used to be glass, and now it's covered by silicone. But you'll see on gonioscopy, we're trying to make sure that it's really parallel to iris plane and posterior and away from the endothelium. Once that's done, we verify for flow, and then you close over the top. However your closure is that you do for trabeculectomy is what I would say. And it does require mitomycin C on the back end, which outside US we'd been sponging and injecting. In the clinical trial here, it'll be with sponges. But The laser titration is actually kind of what the critical component was. So if you look, essentially what you do is you take your laser and you aim it at one side of the paddle. And if you see the device like under the slit lamp, it makes a lot more sense. But one area moves the paddle to open, the other part that you laser moves the paddle to closed. And there are two channels that you can open and close. So there's several settings that you can actually have, and each one of them stepwise gives you a little bit less resistance, so it can lower the pressure. And what we really didn't understand was how far out could we actually titrate the device? Would it even work to raise the pressure if we did have hypotony? And I'll give you two case examples that I did share at AGS. A lot of this data currently, again, is not published, so I'm showing you like what's publicly available. But that first case, at day 7, they come in and the pressure's 11, and we've been pretty aggressive, like trying to titrate these people down to lower pressures, kind of like what you do with trabeculectomy to get a good end result. And the patient's pressure went down to 6 same day when we moved and opened one paddle to one channel. The next week when they come back, the pressure's now 3. In early macular folds. And so we actually closed the paddle. It didn't see much of a change immediately post-titration, but the next week they're coming back with a pressure of 7. I can tell you the more that we've done now, there are some that can actually get some pretty significant pressure swings same day, usually within 30 minutes to an hour. The second patient, kind of a similar story, comes in at about a month. Baseline pressure is higher than what we want, so we laser one of the paddles, get the pressure down same day to a pressure of 6. They kind of maintain, or pressure of 12, they maintain that low pressure, but we still get a little bit more aggressive. And so we've been pushing the titration to see if it would work. Again, we get a lower pressure that occurs once we laser that second paddle. But then they come back later, and the pressure's riding a little bit lower than what we want, early folds, and in the office, we did laser to close a channel, and the pressure rises. And we've seen this patient to patient in the study. The laser titration, one of the things I get asked is, does it work later on? I was skeptical that we'd be able to get anything past like a couple of months at best. There are people that are like even 9 months out where if you open up another channel, they do get a little bit more flow and the pressure does respond that way. So I think this is a promising device. When we talk standalone, again, subconj is kind of like king in like the world that I live in currently. But I do think that these options are valuable. The other one is the Aqualumen. So this is a device, if you look at the side, it's essentially a 22 gauge needle and it has a notch built into it. This is not my surgical video, but what these devices do is they essentially are creating like a sclerotomy without cutting or opening up the conjunctiva. And so what you'll see the surgeon do is they're going to wheel a dollop of lidocaine just for anesthesia, and the needle is going to penetrate from the outside in. When it penetrates and you withdraw it, that notch over to the side actually cuts a portion of the sclera out. What's currently being worked on is how many cuts do you take, and part of the issue that we're trying to figure out is titrating. How do we get a pressure that's not too low, especially early on? You can imagine that you can drop to hypotony in cases like this, but as you enter through the sclera from the outside in, then once the needle's fully through and that bevel portion's past essentially like decimes or the corneal tissue in the periphery, you will then pull back on the needle as you move it over to the side, and that takes a little bit of a core punch out. So you're essentially making a small little hole there. Once that's done, you still again need antimetabolites, so then mitomycin C is injected in the subconj space, and you're creating essentially a bleb without having taken the conj down, or in this case, leaving a device. Now, standalone options in the TM space, I do think there's value there, especially in the right patient. I think right now where we fail is we can't identify those patients that properly. Again, I touched on this, like disease severity, probably a decent metric, but I don't think it's really like the holy grail of what we're doing here. Another one that's kind of panned out more, I think, is actually the chronicity of drops. So you can have a patient that's relatively mild on drops for like 10 years, might not do as well as a patient coming in with advanced advanced disease, never been treated, and you do TM surgery there, they might potentially have a better outcome. It's not universal, but that's what I'm saying. It's multifactorial. It's not all just disease severity. But in the standalone space, in my mind, in the TM, I think drug delivery is kind of where we should really be looking. And so we designed a stent. Again, these started with first in human trials are now being done. I've done this in like 3 different international sites. It's not FDA approved. We have not started FDA trials yet, but it looks very similar to the Hydrus device. The difference is the tip is conical, so it's more like a cardiovascular stent to where it has less of a tendency to dissect its own plane and maybe dive backwards. It's longer, so again, when we're talking about outflow facility, kind of plateauing or maxing out around 6 clock hours. This is getting closer to 4 clock hours of treatment of the canal, but it also is a pathway for us to do drug delivery. Let me just show you the surgery though first. Again, this is outside US. The shepherd's hook design is to get away from making a separate incision. So it can go through your standard cataract incision. It's very similar to what you see with other stents. Like you're going to incise through the TM, but you'll see that it takes longer to deliver it because it's just more material. And so as that device is going through, again, right now it's a slider inserter. These things could change as they become commercially available. But as we're placing the device, it's tracking into the TM, and it's actually a little bit larger than the Hydrus, so it does put it on a little bit more stretch. The windows there are going to be pretty visible, but it's also very flush with the angle. It doesn't have much of the device that's sticking out. Just that trailing portion does. And the reason that trailing portion does is because we also have the option to put in the polyamide cap that actually houses drug. And this is what's currently being worked on for drug delivery in the long run, but something that's peripheral and not so anterior, not really visible unless you do gonioscopy. And it can be loaded with different vehicles that we're looking at. But that's, in my mind, a good standalone option. You're kind of dual mechanism. You have decent safety as far as the area that you're treating, but the drug delivery component, hopefully that can last for a couple of years, I think would be meaningful. We did touch on the AlloFlow device. I do like using it. I do not use it on like your phaco like patients that you could have done like a TM procedure on. This is actually more of a standalone procedure in my mind because it can be fairly problematic. But the big reason is I like doing it in patients that have failed like a filtration procedure, especially like tube shunt surgeries. And the reason behind that is because certainly this uveoscleral space, you can have IOP spikes and cleft closure that ends up being to a pressure of 50 or 60. With at least a different outflow pathway that's functional, even though you needed to do surgery, the pressure wasn't controlled, there's less of a chance. I do keep them a little bit more heavily medicated. This is an alternate to like a second tube or a diode CPC in my mind. But I'm not a huge fan of like really wide cleft creation. If you look at, again, I liken a lot of what we do, surgery is just controlled trauma. And in traumatic clefts, you can see clefts that are tiny with hypotony and large without any hypotony. The real issue is how do you get the uveoscleral flow? How do you get fluid to move out through sclera? And how do you maintain that space? The width of the spacers, in my mind, is not coming from the company. It's not really relevant. It's how do you keep the flow going and how do you ensure that that continues through the uveoscleral route? So the way that I kind of now prefer to do it is we'll create space, we'll make a cyclodialysis cleft. You can either use a cyclodialysis spatula or an even viscoelastic cannula, and you're creating that cleft, but I'm actually stacking the 2 spacers, and this is sclera. It's designed to just hold that cleft open, but doing them vertically. So trying to get a little bit more posterior. A lot of our UBM studies, when we looked at patients that were doing well with uveoscleral outflow, had flow going posteriorly and around the devices. The width didn't really matter so much. And so what you'll see here with the device, and I don't know if it's on a loop here, yeah, we'll place one of the scleral spacers into that small cleft that we created, and you can use viscoelastic to actually open up that space to make it a little bit easier. So once it's placed, then we'll come back and we'll actually place another one on top of it, so it pushes the other one back roughly about 8 millimeters. So it's kind of similar to what the CyPass was doing. I do keep them medicated, and I don't even try to get them off medicines, even if they're a little hypotenuse, until they're off the steroids, things have cooled off, and then we'll back off on a class at a time. The reason for that is if you aggressively treat the hypotony and you stop the medications, you don't know, and that's the problem with this space. You don't know when things might close, and you could have a pressure spike. Having a patient that's had a tube already also, again, is a little bit of an advantage in my mind. But now they're just going back to back. It's a very small area. It does minimize your bleeding because that's a very real phenomenon, especially the wider that you get, higher chance that you could hit one of the iris leaflet vessels or the ciliary body vessels. And so vertical has kind of been the way that we've been doing it. I'm going to move past this case and talk more about what is really, really exciting in my mind. If we're looking at standalone options, it has to be safe. And if we're looking in the TM space, like no one's going to say that you can get all of these home runs, like driving the pressure down. But if you can really take TM surgery and make it truly incisionless and in the office, I think that would be a very good standalone option. And so this is not FDA approved. It's a very small team of us working on a laser. Now, in the femtosecond era, we're very familiar with how this works. It's super high precision. It's very fast, and it's actually very low energy thermally. And there is a product on the market that well, it's not on the market, but in investigational use that is using femtosecond laser to actually make small little trabeculostomy incisions in the TM. The challenge with it is because of the femto and the laser driver, you have to have the patient position. One, there's supine. So that limits how much you can treat because the air bubbles get under the gonioscopy view. And then the second thing is it's the viewing angle, and that's really the issue, and that's partly because of how the laser driver works. But going from that femtosecond to picosecond, it's longer duration, so it takes longer to apply, but now the optics change. And so you can actually cut your focusing angle down so you don't have to position them supine. Now they can sit up like they do, like when we're doing SLTs. There is very low energy. The heat dissipation is actually so instantaneous that it's really almost unmeasurable for what we're treating. And you can vary the duration of your treatment to actually vary what you do. So you take a system that's quite large and you can break it down into something that is quite small, fitting on the top of a slit lamp for this laser driver. The box is literally about this big. And when you look, just varying it. So if we do a short pulse duration, we can get an SLT-like effect with this device. And if we increase the pulse duration now, and these are scanning EMs that we've done, it's already been performed in patients outside the US, you can actually make a hole with the picosecond laser. The disadvantage, though, is you have to kind of sit there for like 1 to 2 seconds versus femto, which is much, much quicker than that. So really the next phase is how do we keep that laser locked in on that tissue plane to create what I would call, like you could eventually get a goniotomy-like incision in the TM at the slit lamp with the patient upright. And the really interesting thing with this, again, is our whole goal, if we're trying to do safe procedures, how do we move them into an office setting with a low footprint and make it cost effective? And that's why we're working on this. And this is just kind of like a side-by-side. The total energy in the eye, there is an advantage to picosecond. You can control the pulses, but also the cost effectiveness, the size and complexity of the laser driver compared to femto are advantages. But the femtosecond really rules in how quickly that procedure can be done. So I want to appreciate the invite here. I think it's fantastic what New York's been able to do, and especially with the Glaucoma Foundation here. I really do thank you for the opportunity.
Thank you for the great presentation. I think I'd like to invite back Dr. Mitch Ibar to speak on how do we co-manage MIGS.
Awesome. Thank you. One of the things I've heard a couple times already this morning is the importance of collaboration, optometry and ophthalmology working together, ultimately just to take care of the masses and glaucoma patients that we have. And so after some beautiful presentations, procedures, data, how do we take care of these patients afterwards? And so what does it look like to hand the patient back between the referring doctor and the surgical center? Who's going to take care of this patient long-term? Who's going to change medications? How are we going to work through these patients? And so in the MIGS space in our practice, we co-manage probably 80% of the MIGS procedures that we do, depending on the referring doctor's level of interest. Sometimes Omni will stay in-house, and then tubes, trabs, some conjunctival procedures will stay at our office as well. But how do we best take care of these patients, and what does it look like I think at the foundation of co-management and collaborative care is really two-way communication between the referring doctor and the surgical center. And no one is equipped to do their role in this without the other provider communicating. And so communicate, communicate, communicate. I think there's really 4 steps to that. From the referring doctor, what does a good surgical referral look like? What matters? What do you want the surgical team to know? Coming back from the surgical center is, what are some of our watchouts? What are we looking for? What do we need to make sure that this patient knows, and or how do we take care of it if it happens? Again, from both sides, who's going to take care of this patient long term? We have the acute post-operative phase, but then 4 months, 6 months, 12 months later, who's going to do visual fields, check the eye pressure? How are we going to kind of tag team the glaucoma care for this patient? And I think that one is tricky because in my experience, it's really hand-to-hand combat. What one provider is willing to take care of and what another is very different. Some are 1-bottle glaucoma docs, some are 4-bottle glaucoma docs, and it just depends practice to practice. And then finally, what if something goes wrong? From the surgical center, what is an adverse event that the patient needs to come back to our office rather than let's try to handle this over the phone? And so this is a sample referral form that our office uses on kind of a new glaucoma evaluation coming into our practice. Our practice is unique in that I'm going to be seeing these patients for all of their new glaucoma evaluations. Then my partner will lead kind of the surgical process. And so what matters for these? I think after you go below the patient demographics, reason for the glaucoma consult. Seems elementary, but this is an important one for me, and it's mostly around, is this patient progressing? Because I may see them for about 8 minutes. I may have just one set of visual fields and OCTs, but I need to know how aggressive we need to be with this patient. How fast are they progressing? Second, lens status. We talked about that a little bit, but the natural crystalline lens, if this is a cataract, it's going to change my treatment and procedure approaches significantly. And then finally, what prior interventions has this patient already had? Gonioscopy, it's really tough to tell if someone's had previous SLT. Maybe they've had a drug delivery device like Durista. It's fully dissolved. I can't tell if that's been done before. And so how do we know where to go next? Next, recent IOP range and Tmax. Boy, this is the hardest question. I'll tell patients, we're going to ask you the hardest question right now. It's the highest your pressure's ever been. Most patients don't know. And so if the referring doctor can let us know that. And then the recent IOP range, because I have to prescribe a very different treatment path if the recent IOP range has been 13 and we're progressing. It's a much different surgical and treatment approach. Next, current eye medications and medications attempted in the past. I really work hard to not be the doctor who just puts patients on medications that they've been intolerant to or haven't taken before. I chuckle at this adherence part, poor, moderate, and excellent. There's some good studies that say we as doctors have no idea which patients are adherent with their medications and which aren't. And so that seems like a fallacy there. And then finally, as the referring doctor, what are you hoping that we're going to do? It's really helpful to know what this patient procedural wise is being referred for. We don't always go down that path, but it's nice to know at least what's been talked about from the referring doctor. And then second, how do we decide which procedure? We've already had some conversation around this that maybe we don't know what we should be basing our procedural approach off of. What's the ultimate target that we're shooting for? Age is tricky. Age is a determining factor in how I make surgical decisions in glaucoma. We tend to take maybe more risk in some of our younger patients because we have more years to try to keep non-progressing glaucoma. Some of our older patients maybe don't heal as well from some type of subconjunctival or bleb-based procedure. Glaucoma severity in general, we're taking more risk on patients who have more severity at baseline. And then unfortunately, we as doctors have to sometimes prescribe treatments or perform surgeries based on what the label says. Some of our surgeries are labeled for a certain glaucoma severity. How do we change that based on the patient in front of us when the label dictates? Number of medications. I think this is an important and evolving one. I'm very careful in glaucoma not to pin one treatment approach versus the other. And so very rarely am I thinking drops versus surgery or drops versus laser, but is this a patient that can tolerate one medication, maybe 2 bottles of medication, or am I trying to prescribe a surgical or procedural approach where we're medication free, at least for a period of time? And then finally, the pre-op IOP. Remember, if we're working with angle-based procedures in the MIGS space, we have episcleral venous pressure on board through the conventional outflow pathway, around 8 to 12 millimeters of mercury. And so if our pre-op IOP is 13, I'm probably not going down the trabecular meshwork bypass stenting route for this patient. We may need to go lower if we're progressing at this pre-op IOP. Here's another way of showing that same slide, but now just giving you kind of a surgical approach or how we tend to make decisions on what procedure this patient is going to have. And so in general, if I want to maximize safety and a visual recovery, especially if I'm thinking of an advanced technology IOL, we tend to stent first in our practice. If I need a little bit greater efficacy and long-term safety, still canal-based procedure. So trying to work in the conventional pathway when we can. If we need greater efficacy, this is when subconjunctival procedures or MIBS comes into place in our practice. Then if I have quickly progressing glaucoma, normal tension glaucoma, uveitic, neovascular, that tends to be Zen or tube in our practice. What about IOL selection, though? We said earlier on that we have about 1 million patients per year in the US that have comorbidities of cataracts and glaucoma. What if we have a patient in front of us with mild to moderate POEG? We're going to do cataract surgery plus MIGS. What are our IOL options for these patients? This is published out of our office, some of my surgical partners here, on can we place advanced technology IOLs in these patients that we're doing MIGS procedures on. This was a retrospective study, 125 patients. 75 patients had cataract surgery plus trabecular meshwork bypass stenting. 50 patients had phaco alone. And then we looked at the achieved manifest refractive spherical equivalent and the astigmatic error post-surgery. And the conclusion's really at the bottom. There was no difference between cataract surgery alone versus cataract surgery plus MIGS as far as the refractive outcome. These are pretty refractively neutral. I think contrast sensitivity, of course, is so important in our glaucoma patients. Our newer IOLs, even some of the distance and near correcting IOLs, are maintaining more contrast sensitivity. And so I think we can be a little bit more aggressive, if that's the right term, on some of these patients who may want some refractive outcomes at the time of their cataract and glaucoma surgery. And so after this patient's had surgery, they're going to go back to the referring doctor. Now, how do we transfer care? On the top left, this is the full sheet of transfer of care information. On the bottom right is blown up for just the right eye, and I think some of the essentials or things to know. And so it's a cataract patient. We have our diagnosis codes. It's a Medicare patient. iStent inject was placed at the time of cataract surgery. We have a monofocal IOL, arcuate incisions, and a refractive target of plano. As an optometrist, I've actually never been on the other side of getting these patients back because I've always worked in a surgical center. But if your patient comes back and they're minus 150 and someone doesn't tell you, I bet you're pretty surprised. And so getting these sheets back is really important. The post-op notes back to that referring doctor are important. Transfer of care and then global period end date, of course, are going to dictate some of the billing and coding. And so this patient's now back at the referring doctor's office. What's step number one in caring for a patient post-op glaucoma surgery and MIGS surgery? I think it's really understanding the anatomy, having this refresher of where the stent was placed or where the tissue was excised out or maybe where there's going to be a bleb. And so really everything on the right side of this slide, you're not going to be able to view the area of surgery, the stenting, without having a gonioscopy lens. And so playing in the perioperative care space for MIGS, you really have to be comfortable and confident with a gonioscopy lens. On the left side, if we're doing a subconjunctival filtration procedure or some type of incisional surgery, it's going to be bleb-based. And so the referring doctor needs to be able to look at the anatomy of the bleb. No, is this a bleb that's cystic? Is it raised? Do we have flow going through it? And so I think glaucoma co-management in the surgical space, anatomy is a really important first step. And then how do we follow these patients further, whether it's standalone MIGS in our practice or MIGS at the time of cataract surgery? We really keep our follow-up schedule the same as if it was a cataract alone patient. And so 1 day, 1 week, 1 month, 3 months, we will change that based on IOP or visual acuity. Here's some of the watchouts. We talked on some of these already, but IOP, if it's an angle-based MIGS procedure, you can get some IOP spikes. If it's in the first kind of 24 to 48 hours, most likely going to be retained visco. If you're comfortable, go ahead and burp a paracentesis. Make sure we get this patient on an aqueous suppressant. If it's more kind of 7 to 28 days post-surgery, this is most likely now steroid. These are pretty minimally traumatic surgeries, and so I'll start to titrate down the steroid or get it off the eye faster. Slit lamp exam, may see a hyphema. We'll talk more about that. Gonioscopy, do gonioscopy during the post-operative period after glaucoma surgery and bill for it. And then setting new kind of baselines. If we have a severe glaucoma patient, new OCT visual field baseline is usually going to be at 3 months in our practice. And then if it's more mild to moderate, more 4 to 6 months post-op. And so what are our watch-outs? We said that in the definition of MIGS is safety, just like our Jamaican friend here with his hard hat on, just not covering his melon. And so what are kind of our watch-outs for minimally invasive glaucoma surgeries? We've talked about most of these, but IOP spikes. These can happen. You can almost always manage these, I think, at least acutely with aqueous suppressants, burpa paracentesis if you need to. Microhyphema, time is our friend with these. We'll have another slide coming here on hyphemas, but these are going to get better on their own. You don't have to load a bunch of steroid on, as Arsham said. I see some of these patients come back and their pressure is 45. They've been on steroid 6 times a day for the last 2 weeks. It's not the hyphema at that point. It's most likely the steroid. We're going to see these much more commonly in cutting and suprachoroidal devices compared to trabecular meshwork bypass stenting. Hypotony, can it happen? And so remember, episcleral venous pressure is our goalie against hypotony. If we're working with angle-based MIGS procedures, stenting, goniotomy, canaloplasty, OMNI, you really should have a backstop of the IOP going too low. If you're doing a suprachoroidal surgery, if it's a tube trab, you can get hypotony, and it's oftentimes kind of a waiting game for that to come back up. There's some different intraoperative things you can do as well. Endothelial cell loss. Suprachoroidal devices have put a bright spotlight on endothelial cell health and endothelial cell loss after surgery. There was the voluntary withdrawal of CyPass. It's really only been in the suprachoroidal space that this has been a concern as far as getting to that threshold of about 30% or more reduction in endothelial cells. But again, this is going to continue to have a lens on all of our new procedures coming to market in drug delivery and in glaucoma surgery, looking at endothelial cell loss. And then finally, peripheral anterior synechia. This can happen in the Hydrus pivotal trials. It's about 13%. iStent inject right around 6%. The iris basically gets pulled up on top of or into the stent. We've had some success in our practice doing a little bit of YAG laser right to the iris here and getting that to withdraw. Zooming in on post-surgery hyphema, I think this is one of the biggest pre-education points to patients of what can happen, the potential adverse events after MIGS. These pictures on the bottom here from left to right, this is really about 14 days in a patient. And so these can clear pretty quickly. Time is our friend here. In the MIGS space, having to do an anterior chamber washout after MIGS is probably 1 in 75 in our practice. It's really not that common. I usually won't, on the picture on the right, add any type of aqueous suppressant. If the eye pressure is normal, I'm not going to cycloplege that patient or have them sleep elevated. On the picture on the middle and the bottom left, I would. I think you want to start to get that to clear, but this is really patient education here. And again, we're going to see this much more in tissue removal procedures compared to our stenting options. So the single number one question I get asked by externs, our residents, by colleagues on how to manage minimally invasive glaucoma surgeries postoperatively is, when do I add, remove glaucoma drops? How am I going to titrate the medications long term? Take a deep breath. We're just managing glaucoma here. But at its foundation, if I'm working with a patient who we did an angle-based MIGS procedure on, we still have steroid for usually about the first 4 weeks, I'm a little cautious taking off topical glaucoma medications too quickly. And so if you're just starting in the MIGS co-management space, start slow. Keep the glaucoma drops on a little bit longer. Once you get the steroid off, then start to peel back medications, usually one at a time. And so angle-based MIGS, be a little more cautious with taking off the meds too quickly. Zen, PreserFlow, some of our tubes, trabs in our practice, we're going to take off all the medications right away. I want aqueous pushing through that new system that was just created, and then we'll add back from there. But again, at its core, we're just managing glaucoma here. And so if you have a patient who looks like this on the left, the pressure after cataract surgery plus angle-based MIGS goes from 20 to 17. 4 months later, visual field and OCT looks like this still on the left. Give that patient a chance. Take off a medication, see what the pressure does. You can always add back. Conversely, if you have a patient who looks like this on the left, 3 months later after MIGS procedure, pressure goes from 20 to 14, but now the visual field in OCT looks like it does on the right. Probably can't take off meds. You may have to be more aggressive and add here. And so let the visual field and OCT dictate how you're going to add and remove meds for these patients. This is to reinforce the importance of collaborative care in the MIGS space. This is data from Q4, again, from Market Scope in their glaucoma surgery space, looking at the amount of procedures being done in the US. And so there's some data that says from 2020 to 2050, we're going to have a near doubling in the amount of glaucoma patients that we're going to have to take care of. And so the volume of procedural approaches is going to rise just because of patient volume. There'll be plenty of glaucoma for all of us. Here's some of your big take-homes, though. From 2017 to 2024, laser in the US has tripled. So we're doing threefold the amount of laser trabeculoplasty that we were in 2017. If you look very closely at kind of yellow and orange, that's your tubes and conjunctival stents. They're about stable to maybe slightly declining on the number being performed. And then the big growth in the MIGS space and the surgery space is really canal-based MIGS procedures and stenting options. And so you'll continue to see these numbers rise because of the volume of patients that we have to take care of. And here's some of kind of the tenets that we will live by or kind of stand on. And I'll pass it to my colleague, Poonam.
All right, so I want to just present a couple cases to discuss what my thinking was in these, and I open it up to anybody who'd like to participate to our panel here to see what they would think. So just to start off, I think all patients are candidates for some form of, let's call it MIGS intervention, whether it be intracameral medication, laser, surgery, at some point in their journey. And I really want to emphasize that it is a journey, so you need to meet them where they are. Building trust is key early on. So I always have a very extensive discussion, whether it's a first-time referral to me, if it's somebody who's been within our practice, what is my take on their disease? If they have some previous information, it is always helpful. But just to establish this is where your disease is, this is where it started, because a lot of patients, they don't know when it started. They have been on the blue and the purple for 5 to 7 years. They can't tell you why or how it was started, but that's what their baseline is. So then what do you tell them? You say, this is your disease. This is your nerve. I describe the donut shape of the RNFL. That's sort of my spiel. And I think my technicians are absolutely sick of hearing it by the end of the day. But we say it so many times because allowing that basis is important for going forward. Co-management to transition from medical care to surgical is key, and then back to medical care, and then back to surgical. So this is going to be a process. So I had this lovely 80-year-old patient who was referred to me. She had had an LPI in both eyes, which she was not aware of that she had had. And that's always an interesting conversation to explain to a patient that there's a hole in their eye they didn't know was there. But describing why, describing that their outflow was insufficient because of an anatomical consideration. It was not necessarily due to trauma or anything else. Describing hyperopia was key in discussing with her. She had first time seen her visual fields. I will always have their imaging up when they first walk in the room. I will turn the computer away from them because some do not want to see it. And you have to know your audience. Some do not want to see all of the visual field loss. But when you discuss with them, would you like to see the impact on their vision? It's important they see it, especially if we're going to elevate to a surgical talk, because post-operatively, unfortunately, as opposed to maybe straightforward cataract surgery, they're not going to have a wow factor day one. We sort of don't get that joy with a lot of our patients, but we want to set a realistic expectation. So this lovely patient had real disease in her left eye. She had had significant visual field loss. She was not aware of this because she is not somebody who's doing activities that require her to have optimal superior peripheral vision. And so describing this to her, she was a bit alarmed, but she had visually significant cataracts, about 3+ NS. Her vision was about 20/50, 20/70. She was not able to be refracted better, so our optometry colleagues had seen her and said, you should be considered for cataract surgery. The discussion of glaucoma was sort of left up to us because, again, she didn't really have a baseline, so we wanted to repeat the testing and present it to her. So in this case, I discussed with her options. She did have an open angle with her LPI, but as Dr. Sharbani very nicely explained, on gonioscopy, I did have to indent to get a clear view of her TM. It wasn't 360 degrees available, and so I had a discussion with her that your cataract is likely contributing to this. Cataract surgery is glaucoma surgery in my mind. So having the conversation with her that we have many options from less invasive like cataract surgery and possibly a MIGS, all the way up to, let's say, a trabeculectomy or a tube shunt, which in her lifetime she may need, we are sort of deciding amongst all of these. The first time a patient is discussing glaucoma, a lot of times tube shunts, trabeculectomies they're fearful of this, reasonably so. So I presented with her that we can start with something like cataract surgery and angle-based surgery. This is low-hanging fruit, get you more functional, open up your natural anatomy. And I often say that's kind of trying to get your own body to start working on its own again. This is something that they feel more comfortable with oftentimes rather than jumping to an implant. And so I do skew towards more of a gonioscopy canaloplasty approach than a stenting procedure. I also think patients who've had an LPI who are somewhat narrow, they are more prone to having that PAS formation because the iris is going to follow whatever outflow you've created. And so they may not be an ideal candidate if they have had an LPI, if they're a bit narrow. So we performed, I'll actually leave it open if Dr. Shaban, you want to add anything about surgically what you would.
No, I agree with you. I mean, I think like the better we get at treating mechanism, and you have randomized studies. I mean, Clement Tam out of Southeast Asia, these are over a decade ago now, randomizing TRAB to phaco for angle closure patients actually showed like very comparable IOP results, better med reduction on the TRABs, but also more complications and more reoperations. So mechanism, I think, is critical.
Absolutely. I think knowing how it started is important. And not to say that the medications were not treating her. Now, her pressures were about 40 and 32 in this eye. And we tried to discuss compliance. I actually had her come back a month later because she felt that could be more compliant. So I had her see her optometrist about a couple weeks later. There was no adjustment. We readjusted again. There was no adjustment in her pressure. So I said, this is where we are. Your pressures are far too high. So we decided to perform cataract and canaloplasty goniotomy for her. She had been on 3 agents prior to surgery. Post-operatively, she's now 20/25 in both eyes. Her pressure is 12 on just 1 agent. So we reduced her medications, we improved her visual function, and I won't say we improved her disease, but her visual fields were clearly somewhat impacted by her glaucoma. And so we have a functional improvement. We have ideally stabilized some of the progression of her disease, but there's a very realistic conversation that in the future things may change. Her glaucoma may still progress, so this is not the end of the line. So I think in the co-management sphere, understanding what the patient's options are, presenting them, and if you have a wonderful partner like Dr. Ibach, you have a great introduction to what the options are, but then telling them that this may not be your last surgery, but that we can start here is important. The trust was built with this patient. She's now following, we've seen her about a year and a half out, and she's very happy. So I think there's a success story that can be there, but we always leave it with the caveat that something may change in the future. So we have a post-op recovery that we wanted and some stabilization of her visual fields. This is unfortunately a slightly different case. An 82-year-old male presented who had very severe glaucoma. He had been managed for many decades, and he was actually very conscious and aware of his disease. Unfortunately, he had severe vision loss. We intervened here in the arrow on the left, the red arrow. So in the bottom of that image is his earliest visual fields, and you see that there has been notable progression throughout. And so we told him very realistically, given that you are essentially monocular, this is your good eye, your left eye, we want to intercept the disease as quickly as we can. In my mind, a lot of these patients, his initial presenting pressures were about 17 to 20 on multiple visits. He's a trabeculectomy candidate. I think from a medical standpoint and glaucoma-wise, he would be a good candidate. But that is not necessarily the end of the story. This is a gentleman who likes to play golf. He's monocular, but he also has a wife and him like to travel. They really want to be as active as possible. And when they're coming in for visits, and I tell them a trab, you may require every week visits to cut sutures, to do needling procedures. He was not very thrilled, to say the least. So they went home and thought about it. They came back with their son. So you know when more family members start coming to the visits that you really got to be on your game because there's a lot more eyes, there's a lot more ears here. So we had another conversation. I said, you have a 20/30 cataract, but you are 82 years old. That the density of that cataract, the lens thickness, we may not measure on every patient or discuss that in the office, but it is significant. I said, we could try something less invasive if you would like, which may have a shorter recovery time. We discussed a trabeculectomy suprachoroidal option, fears of suprachoroidal hemorrhage, and they were immediately off the table for that. So I said, I understand if we come back to it in the future. So we decided to go with the safer option. We did a cataract and a trabeculectomy. A cataract and a goniotomy, I'm sorry. He was on mastocytosis therapy and allergy to Simbrinza. Unfortunately, at hour 3, he developed an 8-ball hyphema. So the safer option that we picked ended up with the outcome that we're all afraid of. I was still in the OR. It was one of those 10-hour OR days, and I get the call 3 hours later. He didn't go home. He came straight to the office. It was a very, very slow clearing hyphema. He was on anticoagulation, which I had discussed with his cardiologist preoperatively, and they did insist that we should continue it. I did mention this to the patient as well preoperatively. I did say, as we all do, that less than 1% often develop this hyphema that requires a washout. Many are minimal that can be observed with positioning, possibly steroids, etc. He was that 1%. And so we discussed washout several times. We watched him very closely every 2 to 3 days. Some of those visits, we frankly were not even looking at the exam necessarily, but just checking in to make sure he felt comfortable. If you remember, this was a monocular gentleman. This was his good eye at 20/30 preoperatively. Fortunately, the hyphema did clear. We went back and forth because there was a concern for some of that hyphema spilling over into the vitreous, which was further limiting his vision. It did take a very long time, but he did clear. And at 2 months, and now later at 1 year and 3 months, I recently saw him, he is 20/25 and his pressure is 10. So I think that there are risks with these surgeries. We are presenting a lot of great cases and these beautiful options, but you don't know what the post-operative period will be. And if you have an excellent team, you can coach these patients through that period. His visual field, as I had shown earlier, it actually was stable still at 1 year post-operatively. And so I think one important discussion to have is, what is the strain for this patient? Is it that they have allergies to medications? Is the cost the burden? What is their lifestyle? Are they going to be able to manage the post-operative challenges, and what is the benefit between those two? So we need to know our goals. These patients obviously had good outcomes, but we do have the patients who develop a spike from these hyphemas, and then they move on to a tube shunt surgery. So being realistic is important, and that is a collaborative approach that we can take with our optometry colleagues. Thank you so much for having me. It was really a pleasure, and these topics could go on for hours, but thank you for listening as long as you did.